I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. I am pleased tonight to have as my guest Anand Murthi and some other guests who I will introduce as we go along. And I'll start now with Dr. Paul Sethi, Dr. Rafi Mirzayan, and Dr. Joseph Aboud. First, I'd like to ask Dr. Murthy, just introduce yourself however you want.
Thanks, Ira. First, I want to thank you for this platform. JOEI has been, I think, is and will be the future of education, both in the journal, online, digital. You've done a great job with your team and Beth and Laura. And thanks for my crew, Paul and Rafi and Joe. And we're going to plug Shoulder 360, the best meeting Miami ever can have. And I hope more people could sign up. And I think Joe told me they're getting great registration. So I'm Anand Murthi. I'm the chief of shoulder and elbow surgery at MedStar Union in Baltimore. I run the fellowship there. My practice is limited to shoulder and elbow, and with three other faculty on tonight, really involved in education. That's kind of my passion. And hopefully we can learn a little bit and talk about stemless arthroplasty and outpatient surgery and pain treatment tonight. Thanks, Ira.
All right, Rafi, it's a couple of words.
Hi, I'm Rafi Mirzayan, one of the co-founders and co-directors of Shoulder 360. We had an amazing course last year. We're set to double our attendance, and we're going to make it even bigger this year. So I encourage all of you to come and join us April 13 to 15 in Miami. Thanks, Ira.
Great. And Paul Sethi?
I'm just looking forward to tonight's Journal Club. I'm looking forward to 360. Hopefully the didactic will be fun, exciting, and interactive. And that's really what we're about, educating ourselves in innovative ways.
And Joe, Dr. Joseph Aboud?
Yeah, hi. Thanks for having me on, Ira. Thanks for your friendship and all the faculty here is friendship. Lara, Beth, everyone on here, Kevin, Matt, Samir Nagd. I see a lot of familiar names on here. So it's great to have everybody here. Looking forward to the conversation. Thanks for helping promote Shoulder 360. But above all, thanks for all you're doing for education.
Thank you, guys. A lot of people lead the way. I think I'm just documenting it. That's it. So I'm going to show my screen for a second. Okay. This is the article we're going to be talking about. I think you can see my screen.
Yep.
Stemless humeral implants in anatomic total shoulder arthroplasty. Here's the authors. This article was a beast of an article, 836 views. That's a lot of views for a single article to get. We're going to talk quite a bit about the evolution of total shoulder arthroplasty, the value of what this article brought, and where some of the current trends are going, and what I unfortunately have to say as a joint guy, the sports world, the shoulder world is really the most innovative space in orthopedics right now. And I'll say that at ACUS this year and embarrass all my colleagues. So we'll make sure of that. So first, I'm going to stop the share for a second. And what sort of got you thinking in terms of this way of stemless arthroplasty? Start off with that. Let's see where we go.
Yeah, it started a long time ago. When I was fortunate to train at Columbia with Dr. Biliani, kind of the home of shoulder arthroplasty, and I'm a historian of shoulder arthroplasty. And Dr. Neer in the 50s and 70s, he began with a stemmed implant, kind of basing it off what we had the knowledge of in hips for stability. And, we only had certain kinds of implants we could use and create and make that would give that kind of geometrical fit. But as time went on, Dr. Biliani designed the BF, kind of a modular system. But, if you think about a shoulder, a non-weight bearing joint, you don't need something that goes down the center of the humerus for stability, really. And that kind of limits what you can do. And we'll talk about that in a little while. So that led in to resurfacing implants, and then often to what we use now are stemless, and that came out first in overseas in 2004 with the tests, and now you see the explosion of stemless implants. And I think we can ask our faculty, but I think the majority of many surgeons now and those in training train with stemless.
Yeah, is that right, Joe? Some comments on that?
Yeah, I mean, if you watch the evolution of first generation, just like Anand said, second generation, third generation, now fourth generation implants, but more and more bone sparing, shorter and shorter. A lot of it is, based on historically what was done, and you have to go through the FDA process to be able to go shorter, depending on what they say is the next size, whether it's standard stem, short stem, and now canal sparing or stemless. With every iteration of technology, there's always things you got to watch out for. And so, we have definitely a good track record of stemmed implants doing well for long periods of time. And then as we innovate, we create solutions. Sometimes we create other problems. We just got to be careful about, that innovation, love innovation, but also have to be careful that you're doing the right thing by promoting things for your patients and being a KOL and promoting it as a leader to other surgeons, potentially, if it's not necessarily the right thing.
Yeah, Paul, when you use total shoulder, anatomic total shoulder, you moved to stemless implants, and what are some of the advantages you found?
So I'm about 95% stemless right now, unless there's a specific reason that the bone won't accommodate it. I think before I talk about the advantage, I would submit that a stemless implant, while seemingly easier, I think is a harder operation because it's less forgiving in terms of your varus valgus and as well as your version. So I think you have to be more accurate in your first cut. And when you use a stem, then you can use an intramedullary device to subsequently make corrections. So I do think it's technically less forgiving. From an advantage standpoint, it's a little bit faster. And in a revision setting, Joe can tease me. I just sent him a picture of a revision I did tonight. Look, I had to do a long osteotomy, and it was a very challenging operation I had to do tonight. And that doesn't exist when I have a stemless because I'm not worried about diaphyseal fixation that isn't always relevant.
Right. And Rafa, your experience in recent years with this technology?
Sorry, Ira, my experience is very limited with shoulder arthroplasty. I'm a sports fellowship trained guy who's dabbling into reverses for massive cuff tear. So
we'll
my
get
experience
to that
is very limited.
Okay, that's okay. We're going to get to that later.
Yeah, I'll defer to people who a lot more smarter and experienced than me, like Anand and Joe and Paul, to answer some of those questions.
We're all good. We're all good.
Harder, just for the record.
What's that?
I'm glad Rafi said smarter, just for the record.
It is for the record. It is for the recording. By the way, I want to tell everyone, if you have questions, please put them in the chat, and I will call on you to have your question absolutely answered by some of the faculty. I mean, I know you very much are involved in development of implants. What does it take to go from an idea that you have while you wake up in the morning to it being on the shelves at MedStar?
I'll tell you, I've had great experiences. I've had bad experiences. Joe will tell you, he and I have been on some teams together that have created some great products that unfortunately didn't make it to great marketing. So, I'll tell you this little bit of the story of the stemless system or the shoulder system that we created. And I think some of my colleagues from the Ignite team are on the call today. They were essentially a startup, Brian Hoderick and Matt Purdy, who had left Tournier with incredible knowledge in engineering and business and marketing. And they put together this incredible design team, and where we all came together with a lot of different experiences and created an entire shoulder system with the kind of backdrop of trying to create something that was efficient, just 2 trays. We're moving to ASCs. We'll talk about that in a little while.
Yeah.
Be able to use them in an ASC, and also to be compatible anatomic reverse, stemless, short stem, regular stem, whatever you want, fracture stem. And with the small companies like a startup versus working for a big four company or trying to design, the speed that you can bring things to market when you develop an idea, prototype literally in a day. You can make a prototype in a day with this, especially with 3D printing now.
Yeah.
Trial it and then bring it to a market. We then developed a team with Depew, which obviously you need distribution. So you need an idea, you need a great product, but you also need the ability to distribute your great product. And that partnership has been great. And so it takes a long time. You need to have a really collegial working team that puts its ego at the door. And I think that's why we were so successful.
And this is the group, right? Ignite Orthopedics.
Exactly.
And what exactly do they take any idea, or is it just in the shoulder space?
Well, they were, arthroplasty design teams for Tournier.
Okay.
But with this team, we can design whatever we want. We can design arthroplasty equipment, implants, things for sports, things for anything, and that's the advantage of having kind of a small team.
It's interesting. I always say when you have an idea, you need three things, and you mention them almost exactly as I always thought of them. You need the idea, you need the ability to make it, and you need a distribution mechanism. All right. No shortage of ideas.
Joe can comment on some of this too. Abud,
Yeah, Joe.
On good and bad.
Yeah, no, I mean, being, at this point in my career and having done some of this stuff already, you learn a lot. Some of it not successful. That's probably, as we always say, we learn from our failures. And you learn a lot about how innovation happens. I mean, if you sit in a room with design surgeons at a big company, you start learning about, how you can go from a long stem to a short stem, and what are the regulations, the FDA process, the IP you have to get around. And then you have to look at the team they have and what's their penetration in the market, and can they distribute it? And you can have a great product, but if there's no marketing distribution, it dies in the vine. So there's so much involved in it that having a great idea and writing on a piece of paper and it going to launch is really exciting, but I think that's not very common. Very rare does something go from a piece of paper to developing a patent to getting it sold. I think Paul is probably the best example of that on this call. But that is one in a 1,000, maybe a million, right, Paul?
Oh, why don't you comment? Give us your story.
I mean, look, I'll tell you guys a funny story. After I developed the biceps button, I'd really thought about it, and I went down and I presented.
I really think gravity is you're shaking so much. Is gravity on the moon different?
I like it. I presented it to the team, and they said, "No, thank you, we're not interested." So I went back to the drawing board, and I thought through it. I did some biomechanics, and I got really nitty gritty on it. And I flew down to the place to present the topic. And I go to the room. There's 6 engineers and 2 or 3 product representatives and managers, but the boss isn't there. And after about 15 minutes, they're like, "Look, you got to go. Your clock's ticking." So I'm presenting this talk, and I look around the room, and they're all nodding their head like, "No, not feeling this. It's not going to work." And I feel the floor like falling away from me. I'm sinking because I put so much time and effort and thought into this. And then the head honcho walks in, and I back up my deck and I show him about 5 slides, and he walks out of the room. And I was like, wow, I've blown it. My great idea is nothing. And then a minute later, he walks back in the room with a small instrument in his hand. He goes, "And this is exactly how we're going to do it." And he looks around the room and asks the rest of the engineers, "Well, what do you think? What do you think?" And they all nodded their heads like, "Oh, yes, sir."
Great idea.
And
Great idea.
It's a true story. So look, your innovations can be really good, and they could hit and miss just because of someone's emotion on a given day.
I mean, it's so true. I mean, my anecdote was I developed a website in the early 1990s called Bone Home. And then I got together with a group of early venture capital people, and we renamed the site, and we renamed it Medscape.
Yeah.
And so the 12 of us were the 12 founders. I went to the AMA and presented it to the board of counselors. And George Lundberg, the head of JAMA and the head of the AMA, said, no one is ever going to want to communicate on this medium.
Wow.
And we left totally depressed. And the joke was about 5 years later, we hired him for Medscape to become the editor.
No way.
Yeah, he saw me in a hall. He said, I think you were right. You know?
That's great.
That's
Yeah,
great.
It's a funny story. Yeah, so let's talk a little bit about some of the does the stemless implant allow for a smaller exposure, less pain? I mean, is it all its promises?
I think the advantages technically are that you can do it with a little bit less exposure, especially in large men who have a huge deltoid, where instrumenting the humerus can become difficult, kick you into some malpositioning. So that's a little, gives you a little bit better on exposure, a little easier. But for me, it also allows you to place it exactly anatomically. And that may be for some people who are more experienced, but you can learn that, you can teach that. It gives you the ability to use stemless stems, short stems, long stem, but also in the way we designed ours is that you can convert to reverse as well, and using the same collar and the same instrumentation. And maybe Joe or the guys can talk about potentially using stemless reverse in the future. I know Joe has had some IDE experience.
Yeah, I mean, I think that, like I said earlier, a good stemmed implant is a good stemmed implant. But when it goes bad, a bad stemmed implant is a lot bigger of a disaster than a bad stemless implant, because obviously the amount of bone you save, the soft tissue attachments, the burden of the revision. So I think the first operation can be easier if you know what you're doing with the stemless. But the second operation, that's where you gain if you have to go for a second operation. And we know people have cuff failures. We know people just have problems with an anatomic and they have to be converted to a reverse or what have you. They have a problem with an implant, period. They have a periprosthetic fracture. And a periprosthetic around a stemless is a different problem, but probably a little bit easier in some ways than around a long stem implant. So those are the things that I think that are 2-3 steps down the road that you don't necessarily see the first step. Yeah, you can talk about pain, blood loss, shorter operative time. Those are all great things. But the bone saving that you have for future surgeries is, I think, valuable. Stemless reverse is, gaining steam. There's multiple IDEs going on in the United States. It's been available in Europe for quite some time, like most new innovations. And I think it's an exciting possibility. But again, it creates its own differences and problems. It's not an anatomic, it's a constrained system. The loads on the humerus are different. You have to be careful about things like what we call inlay and onlay and flush lay. And so those are all new things that we'll have to think about and see what the 5 to 7 year, 10-year data looks like.
How do you guys, sorry, go ahead.
Rafi, I just want to ask Rafi a question about innovation, because he's done so much research on things like the SCR, things that go up and down, quick hitters, maybe plateau. What do you think about innovation and just how we should risk it when we're talking about patient care?
Yeah, I mean, it's a double-edged sword, because unless we innovate, we're not going to make progress. You just always have to have the patient's best interest at heart. Are you doing something that's going to harm the patient if it fails terribly? Every time I push the envelope or do something, I'm like, what's my bailout? If this fails, am I hosing the patient? Is there going to be no bailout for them? And if there is a bailout, then I'm willing to push the envelope. And I am, I am like that. Nothing that I do now is exactly what I did 20 years ago when I finished fellowship. We're constantly progressing. But I think it's important to innovate, and I applaud you for coming up with this design and pushing the envelope and changing the paradigm of shoulder arthroplasty, actually. So I hope that answers the question.
Cool. That's great.
Yep. There was another question. Greg Brown, you had a question. You want to?
Sure. Excuse me. All these advantages like less bone loss, I heard with hip resurfacing, and we all know what happened there. So why are shoulders different?
Paul, you want to take that one? Has Paul left the building? I'll take that one. I think, when we talk about, we'll talk about stemless versus resurfacing. We do stemless, one of the biggest differences is that we're not cannulating and preparing deep down the humeral shaft. And when we do a lot of revisions, and we will be seeing more and more and more revisions as we do more and more TSAs and RSAs in young patients. I have 30-year-old, 40-year-olds getting total shoulders these days. And I've also been in practice long enough that big part of my practice now is revising stemmed implants, which is a very destructive procedure. So if I can do a stemless, and I push the envelope to do a stemless in as many patients I can, even some with poor bone, because I know the revision, if I can get a great outcome, the revision will be much less destructive, morbid to them. So I think in the hip.
So can I push back a
I
little
like
bit?
Greg's question, and I would say that, for us, resurfacing never really was a huge hit. I mean, it was true resurfacing because we didn't have a lot of experience with it, like other people like Copeland, and so we oftentimes overstuffed the joint, created cuff tears, couldn't get the glenoid exposure, didn't treat the glenoid the way we should. So the stemless or canal sparing, you're doing still an osteotomy at the anatomic neck, which changes the exposure, the glenoid preparation, putting in a glenoid surface, and potentially some of the issues of overstuffing. So I think it is a little bit different, even though they're similar. They're clearly different in my mind. And I think a resurfacing in the shoulder, at least, different loads on it than a hip, and can be done well. And we've seen Copeland and Levy do it well. It's just what you trained on, right? Just like anchors versus transosseous cuff repair.
Right.
You can do all of those. It's just you have to have trained on it and become facile at it.
If you look at Copeland's resurfacing results, they are on par with a polyglenoid anatomic total shoulder.
So there's a fundamental flaw with this discussion, and I think it plays out in knees with unis versus totals. And so the idea of a uni is it's surgically easy to convert to a total knee. And that's true. And that's what we as surgeons think about. But if you look at some studies like out of the New Zealand registry, the outcome from a uni to a total is the same as a revision total. And so it may be easy to push the envelope and do a stemless shoulder procedure and bail out to something down the road. But one of the biggest predictors of poor outcomes is number of previous surgeries. So I'm not sure you're actually helping patients by pushing the envelope and trying a surgery, and no longer do they have the better outcome with what we know works well now.
I'll have to push back. The difference is that a total shoulder with stemless is the same as a total shoulder with a stem. So a uni versus a total knee, it's a completely different argument.
Well, but the point is if you've got bad bone and your resurfacing loosens and you have to go in and revise it, you've now put the patient through another operation, and I don't think you get the same outcome is what I'm saying.
Sure, we're never going to leave a stemless in that's not well fixed.
Yeah, I think also I make a comment on it because I am a hip and knee surgeon, is that we're looking at such different biomechanics that are stressing a hip and stressing a knee than a non-weight bearing shoulder. So I'm not so sure the comparisons are exactly the same. But it is a great question, Greg. It is a great question. What have you found with pain relief with this versus pain relief versus a stemless implant, or it's about the same?
Perioperatively, so early post-op?
Let's start with the first 3 days, and let's just go 3 to 30 days, and let's see what that looks like.
We can start delving into the perioperative pain control. I think perioperatively, it's very difficult to tell with blocks and, our multimodal in that first week. They're very comfortable stemmed or no stem. But I think when you have less blood loss, less dissection, less muscle exposure that you have to retract, doing it through a pretty minimally invasive incision. They're very comfortable with the stemless implant. And with the multimodal exparel block, Toradol, ketorolac, we can get into that. Our patients rarely take any opioids at all nowadays. So I think it's that adjunct, less bleeding, less hematoma with the stemless implant.
Okay. I'm just gonna interrupt now. We're at the 30-minute point, and I am gonna get a word from our advertiser. Here we
Now
go.
a word from our sponsor.
Now a word from our sponsor, which is not here. It is here. And I am going, can you guys see this? Shoulder 360?
No, we see
No.
Ignite.
We see
No.
Ignite.
You see Ignite, that will be ending right now. Now you see shoulder 360.
There we go.
My apologies
we
to
do.
Ignite, but you got some free press there. All right. I'm definitely looking forward to this meeting, I gotta tell you.
Me
It's
too.
bringing back a lot of good memories.
Been having a great time at the Shoulder 360 course. It's been an amazing first day. There's been great content, great speakers, and it's in a beautiful place. They've really done it just right. Can't wait to come back next year.
Ira, we're gonna have a cigar for you too.
Yeah, I should have started one right now. Yeah. All right, so here's the faculty. While the faculty is going through, Joe, can you tell us about Shoulder 360? This is the advertiser's moment.
Yeah, no, I think the meeting was a great success last year. We worry about every single detail as a leadership team, Rafi, Paul, myself, and we want to make sure we think about every detail for the attendee, the faculty, the industry sponsors, that they get the educational return, the investment return, the time return that they want out of an in-person meeting. We recognize people have a choice of where they can go, what meeting they can attend, how they can spend their money and time with who. We want to make sure this is a welcoming, fun environment, engaging, educational, and intimate. And so, that's why I think we've been able to have the early success that we've had, but we're not comfortable or confident. We want to continue to push and do better each year. So,
Any other comments from the faculty?
I'll make a comment as not one of the chairs who's plugging it. It's really a energetic meeting. The atmosphere, South Beach, great food, great weather, and great education. And Joe and Rafi and Paul just make it incredibly interactive and inclusive, and make a lot of new friends and networking also.
All right. Yeah, that wasn't so bad to have a good advertiser on there. I tried to get Cheetos or something like that, but they were in the
They spent all their money on Sunday's Super Bowl.
yeah, maybe with some computer magic we could flip one of those ads on the Super Bowl
man.
for Shoulder 360. Let's talk a little bit about trends in arthroplasty. What's next? What really is next? You have the reverse came out. It was a real game changer. I really appreciate the stemless design because I have seen in conferences in my hospital what happens to humeral fractures, and where there's a well-fixed cementless stem in there, and it's not like a femur. Femurs are easy to repair, but what are some of the trends that you guys see that are coming down, not only in shoulder arthroplasty, but also in, let's expand it a little bit, in massive rotator cuff repair?
So Ira, first I'll jump at arthroplasty. I would like to see a subscapularis sparing arthroplasty that is mated with computer navigation such that it can be done in an effective and repeatable situation for most surgeons. And we're not there yet, but I think that will be an important revolution for us.
I think on top of that, I think robotics and mixed reality will be relatively soon coming up. And on the education front, the ability to utilize these type of lenses and Google Lens and HoloLens to educate across the world, where, you know, Dr. X in Buenos Aires can watch Rafi doing a scope and he can teach their team without having to travel and feel like they're in the room. I think that'll be.
I was going to say, when I do my next arthroplasty, you can walk me through it, Anand.
That's right.
That'd be awesome.
It's going to be pretty cool technology, I think.
I think you're right. We had just so you know, we had a journal club with Danny Goel,
Exactly.
and on the Precision OS,
Right.
and that was truly amazing technology. I really wasn't a believer. I thought it was just gaming.
Yeah.
And it really changes the game, so to say, especially for young surgeons. You know, Rafi or Joe, where are the trends going in massive rotator cuff repairs or in shoulder arthroplasty?
Yeah, I mean,
Go ahead.
go ahead, Rafi. Go ahead.
Well, I think the balloon is definitely going to be taking off, in my opinion. But there are other options as well. I think the SCR trend is definitely coming down. People are not doing SCRs anymore. There's a study that just came out where they surveyed a bunch of surgeons and the numbers are down. And one other option is something that I've worked on to develop, and I'll be doing a journal club with you guys. Laura's hounding me already for an article on it called Biologic Tuberoplasty. So there's definitely more and more options, tendon transfers as well, using the biceps for an SCR or anterior cable reconstruction, which Paul has kind of pioneered and is leading the way. I'll also throw it back to Joe to talk more about the balloon, because he's also been a pioneer and leader in that device.
Yeah, I mean, I think, you know, like we started this journal club, innovation, ideas. You know, I don't know how many people know the story of the balloon, but it was developed for urologic reasons by a hip and knee surgeon who was serving on a urology board, who wanted to figure out another application for a balloon that would help with protecting the bladder during radiation for prostate cancer. So he told the board, how about we consider using it somewhere else, like the shoulder? They said to him, that's a terrible idea. Don't ever do that. So of course he goes to Slovenia, does 25 cases, comes back and reports great outcomes. They fire him from the board. So, you know, talk about our idea, how he came up with it. I have no idea. And we all know hip and knee surgeons are inferior to shoulder surgeons. So the fact that he innovated in the shoulder space, exactly, and created such an amazing, confusing technology that in my hands, in my experience, it does work, but I still don't understand fully exactly how and why. And that's the beauty of medicine being an art, not a science. And that's the conversation I have with a lot of patients when I implant this and I explain it to them. They're somewhat confused because it's not 1 + 1 = 2. It's kind of 1 + 1 = sometimes 3 or 4 or 0.5. And so that's the difficulty of innovation in these ideas. It's like some of this we don't fully understand. It's not that complicated to do. And we as surgeons got to sit back and go, well, if it's not complicated, it can't work. I doubt it will ever be successful. Well, maybe simple things do work. Simple and stupid is the best innovation.
Hey, Ira, I have a question. I got texted from the audience. Do you mind if I ask it?
Oh yeah, go ahead, please.
So Midhat Patel, who's going to be a shoulder fellow soon here. Rick Mattson published his provocative paper saying that PROs, shoulder arthroplasty overall didn't show a lot of changes. What's the point? And he's saying what I agree with, because iterative changes lead to big things. Like we changed our concept when we designed the glenoid for our Stemless to a circular glenoid. It's conforming, completely different. And, you know, to say that nothing has changed in 20 years, what do you guys think, Joe and Paul, about, you know, innovation as a whole? And are we really making any change of value?
I mean, I think that if you see iterative change, I mean, I was just saying to my fellow today, we were doing a reverse for a proximal humerus fracture, an 86-year-old gentleman who did not want to live waist level with a badly fractured anatomic neck or head. And so we did a reverse. I said to him 15 years ago, I would have done a Hemi and said to him, let's flip a coin and see if he can ever raise his arm and wash his hair again.
Right.
And today I could say to him, predictably, he'll be able to wash his hair again. Won't be as good as his shoulder was probably before, but it'll be a pretty good shoulder. That's a huge iterative innovation. The fact that we brought the reverse, we started using it for cuff tar arthropathy. Then we started applying it to, off-label use of fracture, and it's good for our patients.
Yeah, and it's gotten to a point where people are talking about just doing reverse right off the bat and just not even doing an anatomic anymore. That's how good the results are. And I remember when I was in my early years of practice,
if you get a reverse, you don't get COVID.
Yeah, we were told to only do reverses in 80-year-olds who are going to die in the next 6 months. That's the only people who should get reverses, and now we're doing it in sometimes 50-year-olds. So there has been tremendous progress in the last 15, 20 years.
I definitely would do a reverse in you, Rafi. That's for sure.
Thank you. I'd only let you do it.
Paul, what do you think about innovation? Does it mean anything? Does it really change value?
We absolutely do. I think the lens by which we measure things is so different right now. So it's very hard to sort of say that we haven't made progress, or if we look specifically at an article that says we haven't changed the healing rate in rotator cuffs. Well, maybe, there is some truth in that. And some of the innovation may be triumphs of technology and industry over what we're really doing. But our understanding of disease, pathology, of who ideal candidates are, and how to optimize those individuals has changed substantially. And that's reflected by our understanding and how we indicate and select patients. So I suspect that the data sets that we produce in the next 5 to 10 years will be fundamentally different.
That's exactly what I was going to say. Is we have been asking likely the wrong questions for the last 15 years, and we keep using the same questions, and perhaps we're not measuring the right questions to get those answers that we actually are looking for. So I think we're going to be doing a lot of different kind of outcome scoring in the next 10 years also.
That's a great point. Like when you look at the ASCS score, the only question about strength is, can you take a 10-pound weight above the level of your shoulder? And if
every patient
yes,
comes in,
it's like,
the little old lady asked Rafi, I'm not throwing a ball. Why are you asking me this question? So
exactly.
we're asking the wrong questions sometimes.
When I was at OSET last year and I gave a lecture and I said that patient-reported outcomes is dead. And if you're doing them, you're asking the wrong questions. We need patient source outcomes. What's a patient source outcome? Like the canary knee, the implantable that doesn't need the patient to tell you, or, a plug for the work that Laura's doing in gait science, where they're using neuromodulation for pain and they're getting information back with the patient modulating the pain so the patient doesn't have to fill out a pain score.
Right.
So I refer to that as patient source outcomes versus patient reported, because there's so much supertentorial nonsense going on with patient reported outcomes, as well as investigator bias.
100%.
Yeah. So pain relief, let's talk about that. What is your shall we say, we had this running joke on LinkedIn, what's the perfect cocktail? And I said, in Manhattan with a little extra orange in it, but what's your post-operative cocktail, and what do you do for day sort of, 3 or 5 to 30? Because that's a critical time for motion and shoulder.
We do pre-op. They have their and most people will probably use Celebrex, something like Lyrica, Tylenol, and then we use an interscalary or brachial plexus XPRL block. That's for arthroplasty, for cuffs, for scopes, for elbows. And with the cocktail they use, it lasts sometimes 2 to 3 days, and then they go home with cuffs and arthroplasty with Toradol for 3 days, ice, obviously, getting up and moving, and then transitioning to Tylenol. And with our system, we actually only give a max of 10 to 20 opioids to even go home with. And I can't remember a opioid naive patient asking for a refill in the last, long while.
Right. Your experience too, Joe and Paul?
Yeah, I mean, I think one of the great things that our politicians have done, which is not many, is the opioid epidemic and really clamping down on prescribing, because it's given us an easy ability to say to the patient, I have regulations. Don't come into my office asking for a refill of 90 Percocets anymore. And that would happen occasionally when I was training with attendings. The patients would just come in for their, monthly 90 perks that they were just going to get from the orthopedic surgeon. That's unheard of these days. And so, we have quality committees that surveillance our practice and look at our prescribing practices for our each subdivision and make sure that we're within one standard deviation. And why is that? And who are our outliers? So, the use and abuse of at least prescribed opioids has, in my practice, seems to have decreased quite a bit. And I feel empowered because a lot of times patients come in and they're difficult, they're entitled, they're threatening, and you're kind of, you're at their disposal in some ways. They want their pain meds. So that's been a big change. But I agree with Anand. Opioid naive patients rarely ask for more than the one script, and they'll take maybe 5, 6, 7, 10 pills maybe during a shoulder procedure, particularly cuff surgery or anatomics. Reverses seem to be much less painful. I don't fully understand why, but they are.
So
I remember. Go ahead.
I'm so thrilled that both of you guys are saying this, because it was just 5 or 7 years ago when the mean prescription, at least in the United States, for arthroplasty is between 60 and 100 pills. And that's just because that's what we did reflexively. So as you discuss this, I think it is true. It's not just one subset of patients. It's not just because you love yourselves as surgeons, but we really have got this under control. And I just need that to be the message everywhere.
But I do think education is a big part of it. I tell my patients they're not going to need it after surgery. Some of them still and then they're actually really happy. I'm not going to need it. It's great. And so they don't have that expectation of one, getting pain, and also needing some type of narcotic.
Yeah, in California, this is over 10 years ago, you had to have, 10 hours of pain CME to get your medical license renewed. And the message was, you're a bad doctor if you're not giving him tons of narcotics. But I do think the Oxycontin epidemic, the patients have heard the message that it's bad. So whereas before patients would come asking for it, now very, very few patients ask for it after their 20 pills of the Norcos or Percocets are done. So I think the whole perception has changed from the patients in the population.
Question. So there was a question from the audience. I'll read it unless the person wants to ask it themselves. Is opioid prescribing really under control, or is it only for select populations? Because it depends on where you are. I have to be
I
honest
think
with
substance abuse in America is not under control, but I think opioid prescribing by physicians, in my experience, is under control.
Okay.
Some of that is mandated, like Rafi and Paul were saying. I mean, they are really watching in Maryland. They can track all of this, and you'll get a report as well if if a patient's getting too many or you're prescribing too many.
Ira, I'll answer that for a second, because I did speak a lot about it, and I think we're trending in the right direction. I think that leaders like Paul Sethi, like yourself, like Scott Sigmund, we've talked a lot about it as well. And so I think that you have a high functioning group that is on this journal club tonight, has great awareness. I don't know that it's trickled down completely, but I think that it's one of those things where we keep having to do the patient education, keep delivering the message. And I would encourage any of you who have not read it to read Empire of Pain, which is a fabulous book. It talks about the whole Sackler family, but also how we all came upon this, and we'll learn from this. And then we just need to keep delivering the message and delivering the message. And ultimately, hopefully, we'll get to the point whereby it is mainstream. but we're getting there, but we're not there yet.
Yeah, I still see in some of the hospitals in New York, especially in the ones that are challenged with social determinants of health and a variety of other things, that they substitute opioids for education. And I think Anand's point of education is important. And if you don't spend time educating the patients about their pain or giving them other options, it depends on the surgery to some extent. No question. Any other comments about this particular issue? Oh, let that go. I had a question about the implant. How do you handle offset in a stemless implant? Is it the same type of
Very good
modularity?
question. Very good question. So right now, stemless to change your eccentricity or offset is off label. So you have to have a stemmed implant to be off to change your rotation or your offset. So you can do it off label, but if you need to, but it's something to be careful about in the really deformed glenoid where you have worry about instability, the inability to rotate or derotate your humerus. So you have to think about that pre-op when you're doing your planning. But that's a good question. Yeah.
Yeah, it's a moment from a joint guy, just a moment. Jacob,
There's a question in the chat room from the chat.
Jacob Triplett has a question. Jacob?
Yeah, sorry. Can you hear me okay?
Yeah.
Yes.
Yes.
Yeah, I was just saying to Dr. Murthy's point, I think the Biomet Nano is one of the stemless implants that does have on-label eccentricity of the humeral head. So I'm pretty sure that's correct.
I'm sure my engineer will make a statement in a minute. I don't know.
And there's a question earlier from Miguel Ramirez. Miguel, do you want to ask it or do you want us to read it for you?
Come on, Miguel, speak up.
Hang on, can you hear me?
Yeah.
Yes.
How are you?
Hi, how are you?
Turn your camera on.
Oh, hang on.
Miguel was my fellow, so I can boss him around a little bit.
Only for the next 35 years.
Yeah. He's the king of shoulders in Peoria, Illinois.
Yeah, right. So my question was, and the trends, in the literature and also in practice, they're trending more towards RSA. The majority of people find RSA an easier procedure to do. So if you're looking at the market, at least right now, if the split is 80-20, even in my practice, like Dr. Murthy had said, a few other people have said, I'm an anatomic first guy and then do reverse if I need to. But I felt like I was well trained by Dr. Murthy to do an anatomic total shoulder. But a lot of people are not, especially as the trends are going towards the approach to total arthroplasty, just an anatomic, what I mean. So the question is, everything that since the trends are moving so much towards reverse, are the companies and people in the innovation moving more towards innovating in that space? Since any new technology they're bringing in, you're only bringing in for about 20% of the market. So the question was, one, do we feel that this trend may continue, or would there be innovation to bring that closer to what it was a few years ago?
I agree. Most innovation is being done on the reverse side just because of the numbers you said and some of the earlier publications you've seen from JOEI, and he's on our team too. But like I answered you in the chat, I think maybe the questions that are being asked are wrong. Like if we're using ASCS scores to compare or things like that, I will always say if you have a 60-year-old who you put an anatomic in that's doing great, their motion is more normal, their physical appearance is more normal. And my risk of stress fracture and instability is zero with an anatomic. Obviously you have your subscap, but that's a pretty rare issue as well. And, there's nowhere to go with a continuous failed reverse. Whereas in the unlikely setting where your anatomic fails early, there's still something to bail out to. That's kind of my philosophy. Joe, what's your philosophy on that? There are some people now well known, our buddies who do anyone over 50 OA gets a reverse.
Yeah, I think it's going to be just like you talk about certain procedures like an open capsular shift. Unless you've done it a lot, you're not going to be that good at it. And so some of the younger generation is being trained by, let's say, surgeons that are 10 years out now who are doing a lot more RSA than TSA. They're probably going to gravitate to the RSA. It's just because they're more comfortable with it, not because it's a better outcomes operation. And I know, lots of thought leaders will say, and do say, and it's true, a better anatomic is any day better than their best reverse. But the problem is, can you do a good anatomic still? Some people may not know the technicalities of that. And an RSA it seems like it would be harder, but it's an actually easier operation.
Great point.
Yeah, no, it reminds me of the argument of cephalomedullary nails in the hip versus DHS. Somehow we don't use DHSs anymore, or omegas, or whatever you want to call them. And the outcomes are not better with cephalomedullary. And there's a whole generation of trauma surgeons or general surgeons who have not trained on a DHS, which, has a great place in being able to reduce the fracture better. So it's the same. It's kind of, to me, an analogy in another world that Joe's talking about, that, when people stop getting trained on an older technique, sometimes it does circle around, and all of a sudden everyone gets, an
That
aha moment.
DHS intramedullary nail revolution started, the argument was industry was driving it. The reimbursement was higher for an IM nail than a DHS. So you had financial recoup and industry innovation was greater in it. So, that also pushed it. So Not only did people not get trained on it anymore, there were other motivations for it.
Absolutely. Yeah.
We've seen a lot of trends where things are direct to consumer marketing, and you see this explosion of use of a device or a technique, and usually comes around and slows down too.
Jacob, triplet again. Come on down.
Yeah, I think I just have an overall question regarding the stemless anatomics. I mean, I've heard mixed things in particularly the revision setting, as far as I've heard multiple people say when they take out these stemless implants, they generally tend to come out relatively easy and do not destroy the metaphyseal bone. And then I've heard other people say that they could be quite destructive to the metaphyseal bone. So, I'm curious to see down the road with the conversions to reverses, where do you think the shift is going to be in the revision process? Is this going to be more off-label utilization, trying to retain the stem and putting the reverse components in off-label? Are the stems routinely coming out? If they are coming out, is there concern about the metaphyseal bone compromise, assuming you're using an inlay stem?
I think some of that depends on the system you're using. So, as I stated, I have a conflict with DePuy, but our stemless is designed as a flush layer inlay mechanics to take a reverse. And so we've had partners who have had an anatomic fail with cuff failure convert to a reverse already. And I think there's some other systems that do that. Taking out a stemless, that depends on what type of stemless you're taking out. Some are still destructive, and some you can take out with, the proper extraction equipment and not remove too much bone.
All right. Just like to sum it up a little bit with some final pointers, or even a final plug for Shoulder 360. Let's go around and sort of how I see it up here. Anand, what's some final thoughts on the topic and Shoulder 360? Yep.
First, I want to just thank you again for the platform. Shoulder 360, it's a great meeting. If you haven't had the opportunity, get registered, get down to South Beach. I think the ability to meet new people, network, and learn a different way of education is great. With regards to stemless, I think once again, education is key. Get the experience, training with someone, going to watch someone do it, meet your industry partners, and I think you'll see its utility.
Rafi, Shoulder 360.
Yeah, Ira, first of all, thank you for the platform. I also want to thank Anand for giving his time to give us this chat on the very interesting and innovative topic. I think, when you think about it, a lot of the courses, the topics are the same. You have shoulder instability, shoulder arthroplasty, rotator cuff. I think it's the way we deliver it and we make it entertaining and dynamic and engaging. So, this is a 3-day course, and on Saturday at 4:00 in Miami, the room was about 90% still full. People just did not want to leave the meeting. We had them captivated and engaged the entire time. So, and we plan to do it again this year. So please join us. Thank you.
It's a must-go meeting. Go,
Oh,
Rafi.
Kevin
Go,
Plant has
Joe.
joined us.
Go on.
Thank you, Kevin. There you go. One of our
Godfather just came out of
Paul.
nowhere.
We'll be there.
It's always good to get the thumbs up from the Godfather, Kevin Plancher. and clearly, if you do shoulders, you need to be there. And
Well,
we'll be there.
I thought Ira was the godfather.
Well,
Just-
Ira's the Godfather,
He
but
is.
Kevin
He is.
Plancher is the Godfather in waiting. He's
Yeah.
the
Kevin
consigliere.
Planter is
Michael, wait, which one's Michael?
What's
On
that?
there you
Which
go.
Michael Corleone, Kevin or Ira?
Oh, I just think computers. Paul, some comments on Shoulder 360.
I just think you need to get to see what Joe Aboud's going to pull out of the hat. I mean, it's just there's a lot of magic. So we're looking forward to it.
I want some popcorn.
And Joe, some final comments, and also
I
I
would
want a
just say-
prediction for Sunday's game.
So Eagles win by 2 touchdowns.
Ooh,
And for the meeting, if you're registered and you're following Instagram, we're giving away a luxury suite for free with a drawing at midnight tonight. So if you register and you get into the drawing, you get 4 nights in a luxury suite in the Lowe's, which goes for $2,700 a night without taxes, which would
Did Shoulder 360 approve Joe's Eagles shirt? I just want to know that's sanctioned.
Joe is Joe Aboud. He can wear whatever he wants. He's
Yeah,
a
you obviously
star.
don't. The rules don't apply to Joe Aboud. Don't you know who the F he is?
as long as he has a shirt on, we're happy.
It's all good.
good point on it. Very good point.
So I want to say thank you, first of all, to everyone who joined, the participants in the audience, and especially to our faculty tonight. I want to thank Anand for an amazing article. Huge number of views, obviously hit a great nerve. Joe, Rafi, and Paul, thank you so much. Special thanks to Laura Wynn and Beth Best for helping to organize this. And I'll just say good night so we don't keep everybody up too late.